Hi, this is John Wasson speaking on behalf of the Centers for Aging at Dartmouth Medical School. I've been a primary care physician for many years and also a geriatrician. I know over the years how much the heat has gradually increased in primary care practice as more and more demands have been made on us, and of course our time has not increased proportionally. We're like the proverbial frog in the boiling water who feels at some point, usually when it's too late, wow, it's getting hot here. Not to belabor that point too much, over the last few years there have been a number of articles that have totaled up the time required to manage acute problems, chronic problems, preventative issues in primary care. And when you actually total all of that up, we're left with 2 hours for life and sleep. Clearly this is untenable. So this program, Identifying and Managing Dementia and Alzheimer's Disease in Primary Care Practice, takes our time limitation, the heat of the office, very much into account. We think you'll find it very helpful without increasing the heat at all, and hopefully reducing it somewhat. So let's start with the view of care from the bottom up, that is, at the level of the patients, those who come through the door. Roughly 10% of elderly patients aged 70 to 79, 15% of those 80 plus, and a larger percent of those who are low income report often or always having a problem thinking or remembering. These are folks who come through our office every day. If we were to ask other questions of them, we'd find that 70% of these folks are not confident with self-management, 55% don't have good quality of life, many are bothered by pain, are on multiple medicines, feel their medicines might be making them ill, perhaps have emotional problems, risk for fall, social support problems. A lot of stuff that we have to try to assess and manage. What does assess and manage really mean? Well, if you review the literature in the assessment and management of dementia and Alzheimer's disease, here are the activities that we are to engage in with our patients and their caregivers and the community resources that will help them support their lives and the advancement of their disease. There's a lot listed. Given the realities of patients' and caregivers' needs and the pressure of primary care practice, it's not surprising that we sometimes adopt an almost shotgun approach. To illustrate that, consider the fact that the British and many American authorities say medication should be a last resort, if used at all, in treatment of dementia and Alzheimer's disease. Over 90% of U.S. physicians prescribe drugs to these patients in the past year, and those drugs are listed here. Lots of medicines we use as an approach, perhaps out of habit, perhaps because we think they're marginally effective, perhaps because of patient demand in difficult circumstances. Regardless, we may not be doing the best for our patients. Given the needs of patients with cognitive deficiencies and Alzheimer's disease and the needs of their caregivers, it is not surprising that we clinicians refer these patients to many, many community resources. This list from 2 states identifies those resources most commonly used, and you can see there's a lot of double counting. Many resources are used. The question is, are they used wisely and well, or do the patients and caregivers just bounce from resource to resource while seeking the help they need? Given the projected increase in the elderly population and the resultant increase in patients with dementia and Alzheimer's disease, it would behoove us as clinicians to become more efficient and effective in the management of these increasing problems. What are the limits that we currently face? Listed here are those that are most common And those in green are those that we will be particularly focusing on in the materials that we're making available to you. We wish we could increase time and reimbursement, but of course that's outside our purview. As an illustration of a practical approach for primary care, let's begin at the beginning. How do we diagnose dementia? Well, dementia, of course, implies memory impairment plus decline in social and occupational function, and some other abnormalities as noted on this slide. So to begin, you have to decide, does the patient have a memory impairment? This slide shows the likelihood ratio positive for any particular type of test and memory impairment proven later. What you'll find is an LRP near 10 indicates almost diagnostic certainty that you've got serious dementing disorder. As you can see, when a patient self-reports that they have memory problems, there's a slight movement in the direction toward their eventually being proven to have dementia. If the family member confirms it, the movement is even further along the path. And if the patient does not recall 4 unrelated items at 5 minutes, the odds are overwhelming they have a dementing illness. Conversely, if they remember all 4 items, the odds are overwhelming they don't. You can see the clock draw and other tests and other results and short forms shown here. The bottom line, use 4 items. Many primary care clinicians express disquietude about the many non-pharmacologic interventions that might be used for their patients with cognitive dysfunction. This review of the literature, recently published, provides us some solace, so to speak, that we're not missing the boat. There's insufficient evidence that a lot of cognitive training or rehab and many other treatments promoted by professionals and the media make much difference. The 3 main points that we have to remember is, first and foremost, keep a patient exercising as much as he or she can. It seems to help their function. Second, focus on environmental modifications for limitations in activities of daily living. And third, keep an eye on anxiety, since anxiety interventions really do make a difference. Another area in which clinicians express a great degree of disquietude is, how do I put into effect all the patient education and caregiver information that's suggested by the literature? The good news is, from a number of very good studies that have taken place over the years, you can begin to anticipate the type of information that's most useful and most commonly used, as shown here in the parentheses. What we do in the materials that we make available to your patients online is we build on this experience so that you don't have to have a file cabinet in your office, but rather, as the patient goes through the web sites, they get information tailored to their needs. You just have to make sure the patients use the web. Imagine that Bill has brought his mother to your office and is worried about her memory. For all patients who have potential memory impairment, this 3-visit approach is what we'll describe in the next YouTube. Very briefly at this point, in the first visit, you would establish a diagnosis, put the patient and caregiver into an information link, explain a caregiver diary, and then have them expect a second visit or phone call in which you answer questions, review the diary, go into some other links, and then a third visit at a later time where you go into greater detail, reinforce the diary, and also suggest other links. This is it, a 3-step intervention to handle Alzheimer or dementing illness.